Hello, my name's Helena Teede. I'm an academic and a health professional and someone who's incredibly passionate about capturing the voice of the community in what we do in research and healthcare improvement. Indeed, the community in Australia is the funder and the beneficiary of healthcare and the funder and beneficiary of research. And as a member of that community, I think we all deserve the integration of those and to make sure that research and healthcare improvement meets the needs of our community. I'm really fortunate today to be talking to Dr. Magdalena Skrybant, who's an expert in public and patient involvement, as they call it, in the UK, and who's a member of the CLARC in the UK in a collaboration between Monash and Warwick University. So Magdalena's been very generous in coming out to meet with us. I'll get you to perhaps introduce your role if you can, Magdalena, and then we'll talk about some of your amazing experiences and advice.
Thank you, Helena. So I'm Magdalena Skrybant. I'm Patient and Public Involvement Lead for National Institute of Health Research funded Collaboration for Leadership in Applied Health Research and Care, which, as you correctly call the acronym, it's CLARC. There are 13 CLARCs in the West Midlands and we're one of those 13. But they're going to be moving into ARCs, which are Applied Health Research Centres, from October 2019.
Great. So we're really fortunate to have you out here. It's fair to say that I think Australians know that it's really important to have consumer and community involvement, or public and patient involvement as you call it in the UK, in research and healthcare improvement, but we don't really know how to do it, and we don't necessarily understand the capacity building and the training that's needed. We haven't professionalised it, but most importantly we haven't systematised it. It's not something that we do routinely. People do it in many different ways. They don't have to do it to get funding. They don't necessarily have to do it at particular stages. And it's clear if we look at what's happened in the UK that it's just a fundamental ingrained part of the fabric of research and healthcare improvement. And we'd really like you to talk a little bit about what that looks like in the UK and how you think the UK got there.
Well, I think it's fair to say that I don't think we've solved the problem entirely ourselves either. And I think there's a recognition across the UK that whilst we've come a long way in a journey to involving patients and the public and consumers and community, as you call it in Australia, in our research and our healthcare improvement, we've still got a massive way to go. In fact, the National Institute of Health Research in 2015 came out with quite a groundbreaking document called Going the Extra Mile, which is its 10-year strategy for public involvement in research in the UK. And actually in that document it did acknowledge that we've come a long way in the last 10 years, but actually there's huge steps we have to take to making sure that public involvement is really embedded in our research and healthcare improvement. And certainly one analogy I like to use is we talk about patient and public involvement as the golden thread. It's integral to all our research project, all our healthcare improvement. It's this idea that you cannot have a meaningful project that's going to have impact unless you have that insight and that knowledge from people who either have experience of a condition or who live with a particular condition or care for someone that has a condition, or they're part of a community that's going to be beneficiaries of the research evidence or that healthcare improvement. So generally, all kind of work we do, we have patient and public involvement, and a lot of research centres in the UK have someone in a role like mine to help make that happen. I think there's an acknowledgement that patient and public involvement is hugely resource intensive, and it has to be because it has to be meaningful. And for something to be meaningful, it has to have right resource put into it to make sure that those connections between the patients and the communities, there's an ongoing feedback cycle, and that researchers and people who are doing healthcare improvement have that time and resource to be able to do it properly and to do it justice. So that's a lot of my work in making sure that those relationships are ongoing. Actually, talk about relationships, the Going the Extra Mile report had 4 pillars. There were 4 key things they identified in terms of patient and public involvement, and that's really important. So the first of these is reach. Who are the groups you're going to reach out to? Who are the groups that are most relevant to your research or your healthcare improvement? And how are you going to reach out to them to make sure that the people you involve are reflective of the diverse communities that are going to benefit from the research? The second one is relevance. How relevant is the research project to end users, service users? Is it meeting their needs and priorities? It's no use doing something or there's no real value in doing something if it's a pet researcher project or something they've got a particular academic interest in, if it's actually not going to benefit people and make a difference to their lives. The third one is refinement, and that's considering how consumers, members of the public communities, are going to really shape the development of your research project or your healthcare improvement project. But running through all of these is the fourth R, which is perhaps the most important, and that's relationships. And that's how are you going to develop relationships with your communities that you're working with, and how are you going to make sure that those relationships are meaningful, that it's not tokenistic, that it's not a tick box exercise, it's not something you're just doing because you need to overcome that hurdle to get funding. It's actually really beneficial partnerships and working well with people so they can add real value to your projects.
So interestingly, in Australia, we have consolidated some of our approaches. One of the advantages of being a second user in a system is that you can learn from other systems, perhaps the good and the not so good. Interestingly, in the UK, you have these applied research centres. You also have academic health science centres and academic health science networks and many different silos, but most of them compete with each other. And as an outsider, when we look in, it's interesting because there are some really common threads, as you said. So consumer and community involvement, public and patient involvement is critical. The way we do clinical research in an integrated national way is really important. The way we use data to improve healthcare outcomes for the public, the way we work to help the outcomes of our vulnerable populations, and the way we do health services and systems research. In Australia, we've decided we're going to do them collaboratively and nationally because it's really important we do that in a non-competitive way and only to have one type of centre structure, if you like. So we have Advanced Health Research Translation Centres. Monash Partners is one of those. It's the oldest and best established. And indeed, there are now 7 of those centres and 2 centres for innovation in regional health, because we have real challenges around a remote regional expanse, very different to the short distances that you actually have in the UK. So our centres are looking at developing a national framework, and indeed that work's been done, and we've looked at your Go That Extra Mile document and been able to leverage off that. And now it's been escalated, and some of your work you've been doing with us has been really important. We have fellows working in this area, looking at the best of the literature, and are exploring with our consumers, health professionals, stakeholders, consumer groups to see how we can move things forward. And I think if I were to ask you, if you were 10 years ago in the UK and you had a fresh slate, what would you think the core elements that were really critical to retain on your journey, and what might you have done differently?
It's a really interesting question, but I think one of the things you highlighted is the fact that there's lots of different networks, and actually I think that's absolutely critical to really good patient and public involvement, because there's so much we can learn from each other. We're all travelling the same journey. Whilst we all have different contexts and different kind of projects and different kind of research centres, essentially we're all doing this, trying to do the same thing. We're trying to get a really strong, meaningful patient voice in everything we do, right from the start, right to the end. And so actually in my area of work, I work in lots of different networks, very local networks, regional networks, and then networks, for example, all the PPI lead in the CLARCs meet together 4 times a year. And those are absolutely critical because we share so much of our resources. We're very open. We discuss all the things that help us in doing our public involvement, what's worked well, why has it worked well. I did this workshop, this is my framework I used, this is the resources I used. It just makes it's just much more streamlined. But similarly, we'll discuss barriers we have to meaningful engagement and involvement. So for us, it's working with underrepresented communities, how to work when you don't have relevant resources or budget for it. And so we work together to solve ideas. So actually having those strong local, regional and national networks is really important. In terms of doing things differently, it's hard to say. I mean, I think it's constantly evolving journey. It's really important for us to report PPI. That hasn't been done necessarily so well in the past. We now have a reporting framework that's an international guidance called GRIP2. And hopefully if more people use GRIP2 in reporting their PPI, that will help us understand more what works and why it works. A challenge we have is sometimes honest reporting doesn't necessarily take place. When people report PPI, sometimes they do it through rose-tinted spectacles because there's a fear really of reporting things that have maybe not gone so well. And I think that's in people's culture, particularly when you're applying for research grants all the time and you want to have stellar publications. You don't necessarily want to report the things that haven't gone so well. So I think, 10 years ago, it would be really good if everybody did report their PPI, and perhaps if there was like really honest reporting. But hopefully that's changing now, because I think there's a real commitment within the community to wanting to learn and not to waste resources. If something hasn't gone well, I think it's okay to say, it hasn't gone well and this is why it didn't go well, so people don't waste resources longer down the line doing the same thing that maybe hasn't worked. So I think that's potentially what we change.
So that's really interesting, because obviously that lesson isn't just in public and patient involvement, but actually in everything. So it's fantastic to hear that one of the strengths was working together and collaborating across the networks, and especially in consumer and community involvement, that should be something we all share and work together in. But also that opportunity to say that really, if we capture both our learnings from failure and our learnings from success, we'll probably learn a lot quicker. It's not necessarily something that researchers always do really well. Even healthcare improvement struggles with that. So whilst it's a challenge in that context, I think it's a challenge across the board, and that's probably a really valuable lesson for us to think about in the centre structure overall. So what have you enjoyed about coming to Australia, and what might you reflect on in this opportunity?
Melbourne's a fantastic city. I've really loved it, and I've really loved seeing different academic environments and coming to the workshops, working with consumers, working with healthcare professionals, and seeing how your workshops run. I've had the real privilege to be in some workshops where there was so much energy and enthusiasm in the room, which is really lovely. Coming to Melbourne for 2 weeks has actually given me an opportunity to sit back and reflect on what I do and think about the work I do. Sometimes when you're in a role, and I'm a PPI lead, a lot of it's going to different meetings, supporting public contributors. You don't have that time to stop and think, well, what do I do? What's important in my role? What would I change? So I'll come back brimming with ideas of different projects I'm going to do. One thing that I think is really nice here is the collaborations between different academics and the close connections that the academics have with the healthcare services. I think that's really good. But it's just nice to be in a different environment. Sometimes a change is as good as a rest, and it's really nice just to see how things work over here. But it's been a really good opportunity for me to consolidate my resources and actually think, wow, we have actually developed quite a lot. You don't realise when you're working on things all the time how much knowledge you have, and that tacit knowledge is so valuable, an experience of doing a job for 3 years. It's been nice to share that, but equally it's been nice to share resources and experiences that colleagues here in Monash have got. So it's been really useful in that respect.
Fantastic, and we look forward to coming and spending some time in the UK.
Yes, please do. Thank you.
Thanks very much.
Thank you ever so much, Helena.